Hello, everyone. My name is Jessica Porras, and I'm the Senior Manager for Education and Outreach at CAQH Core. Welcome to our first CAQH Core Town Hall of 2019. We have a lot of great information to share with you. Next slide, please. I'd like to mention a few logistical items. You'll be able to download a copy of today's presentation from the caqh.org website tomorrow. In addition, a copy of the slides and the recording will be emailed to you in the next day or so. So just to reiterate, the slides aren't on the website right now, but you'll be able to find them tomorrow. We will save time at the end of today's program to respond to your questions. I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. Next slide. We have a lot to cover during this town hall. We will start off with a CAQH Core overview, followed by a review of recent federal activities. We will then hear the latest findings from the recently released CAQH Index. After that, we will move on to our initiatives and share our progress on value-based payments, attachments, prior authorization, and core certification. So let's get started. I'd like to introduce our first speaker, CAQH Core Director, Erin Weber. Erin?
Thanks, Jessica, and thanks everyone for joining us today. I hope you're staying warm. We are going to start today's presentation, as we do most of our town halls, with just a brief overview of CAQH Core for those of you that are newer to the organization. Core was founded back in 2005 as a multi-stakeholder group driven to develop the business rules to support industry standards and accelerate interoperability. Operating rules are considered the necessary business standards and business rules not defined by a standard or implementation guide. We are governed by a multi-stakeholder board of directors with plans providers and vendors providing the leadership. And we see our role, as you can see from this integrated model here, not just as a organization and group of participating organizations that develop operating rules. We do have about 130 organizations that participate in our subgroups and work groups, but we also feel our role is to drive adoption and measure the impact of the requirements so that we do have ongoing impact on the industry. To date, Core has developed and published 4 phases of operating rules addressing 8 HIPAA transactions. We were designated as the HHS, by HHS, as the operating rule authoring entity for the HIPAA covered transactions, including claim attachments. We'll talk a little bit about some of the new rules we are working on for prior authorization and attachments. I want to share very briefly some of our goals for 2019 as we look at our plans for this year. The first is really focused on our role as the National Operating Rule Author to improve the efficiency and accuracy of the industry-driven business rules. And all of these goals come out of our multi-stakeholder board of directors. So this year we'll be focused on, continued focus on prior authorization, attachments, acknowledgements, should an NPRM come out related to those, value-based payments, and enhancements to our existing rules. Our second focus is around our core certification project, which we will speak in more detail about in a minute, but really targeting specific areas to increase certification in phases 3 and 4, and also within the Medicaid and dental industries. We're also looking at ways to modify our certification process to increase industry value and adoption. And third, we are always looking to improve what we're doing. So our focus will continue to be on driving value in the work that we are doing, and looking specifically, and we talked about this a little bit on the last town hall, increasing the pace of rule development through the adoption of lean and agile methodologies and pilots, and improving value and ROI tracking and messaging across the work products. So I hope that brief overview was helpful. For those of you that are new to the organization and you're looking to learn more or interested in becoming a core participating organization, you can certainly reach out to us for more details. I'm now going to transition to give a brief update on some federal activities that impact the space that we all work in. The first is related to some work that the National Committee on Vital and Health Statistics has been doing over the past year and a half or so. This group is a federal advisory committee to the Secretary of HHS, and one of their specific focus areas is administrative simplification via HIPAA. The NCVHS committee has been looking at ways to evaluate barriers to the update, adoption, and implementation of standards and operating rules across HIPAA and the Affordable Care Act. They have conducted numerous sessions with industry representatives to hear about the challenges and understand the opportunities, and late last year came out with a set of draft recommendations emphasizing improvements across various components of the industry, including for the federal process, improving the enforcement of existing regulations, guidance and outreach and education, improving the federal government's responsiveness to recommendations. Their recommendations, the NCVHS recommendations, also included improvements for standards development organizations, and that includes operating rule authoring organizations as well. Focusing there on diversity of participants, ability of standards to support innovation and evolving business needs, and the timeliness and reliability of updates. The final area of focus is in governance and oversight, ensuring transparencies of processes across the standards and operating rule development and adoption processes, and responsiveness to industry needs. At the end of last year, in mid-December, they did hold a participatory hearing where stakeholders were invited to discuss the recommendations and provide feedback, and they also accepted public comment letters. NCVHS is having a meeting next week, actually, during which they are planning to finalize these recommendations. And those meetings are public, so you can go on their website and either attend in person or dial in if you're interested in hearing the discussion. On slide 10, we highlight some of the key themes of CAQH's comments related to the predictability roadmap, and we would like to thank our participating organizations who joined in a webinar and completed some surveying we did to help formulate our responses. In particular, we highlighted support for where the draft recommendations aligned with our 2019 goals, specifically looking at the expedited development of standards and operating rules, the importance of broad industry collaboration, support for greater adoption of operating rules, and focus on ROI to drive industry adoption. We also gave feedback on how to ensure the recommendations have the greatest impact and value to the industry, and recommended they consider using the flexibility in existing statutes rather than new rulemaking to help achieve some of their goals around predictability. We asked them to keep in mind the potential for unintended consequences of using regulation to encourage innovation, because regulations can be stifling to innovation. And finally, I wanted to make sure it's top of mind, and we heard this, I think, across the discussions at the hearings in December, the importance of benefiting the balance of predictability with the benefit to the business case related to new and updated standards and operating rules. So not making updates just for the sake of meeting timelines, but when there is a real business need. Our complete letter is posted on our website for anyone interested in digging into the details there. A couple other items that have occurred since our last town hall call. On December 19th, HHS announced a notice of proposed rulemaking pertaining to the health plan identifier. The rule actually proposes to eliminate the regulatory requirements for health plans to obtain and use an HPID. This was anticipated. There had been several requests for feedback and information over the past year or so on the value of the HPID, and there is a 60-day comment period open until February 19th for those interested in commenting on that. Also, we continue to eagerly await a notice of proposed rulemaking related to an attachment standard. In the fall unified agenda put out by HHS, it did indicate that this may be coming out in the December timeframe. Obviously, it did not. But the unified agenda indicates that this NPRM, when it does come out, will adopt standards for attachments, adopt operating rules that require acknowledgements to be used for eligibility, claim status, and ERA transactions, and then adopt some standards for acknowledgements as well. And then finally, two more here. ONC, over the past couple of years, has started publishing what they call the Interoperability Standards Advisory. And this is an online catalog of interoperability standards and implementation specifications that the industry can use to address specific interoperability needs. It's a very comprehensive guide and it's publicly available, so I certainly encourage you to go out and take a look at it. Each year they ask for feedback on the ISA, and CORE has made comments. Last year was the first year that administrative transactions and operating rules were included in the guide, and we did make some comments on how to enhance the content around there. The latest version of the Interoperability Standards Advisory was released earlier this year, and it does now include, in addition to the phase 1 through 3 operating rules, the phase 4 operating rules, and update some of the adoption data for the federally mandated operating rules. So we were excited to see that in there. And now the last thing I want to highlight is the ONC's draft strategy on reducing burden related to the use of health IT and EHRs. So as background, the 21st Century CARES Act identified the importance of easing regulatory and administrative burden associated with the use of EHRs and health information technology. They requested that ONC and CMS work together to come out with some recommendations on how to ease that burden, particularly for providers. And so the draft strategy came out, I want to say in October, with kind of 3 overarching themes around reducing the time and effort required to record health information in EHRs for clinicians, reducing the time and effort required to meet some of the regulatory requirements around reporting, and then improving the functionality and intuitiveness of EHR systems. CAQH Core did submit a comment letter. There were kind of 2 areas in particular where I think some of the work that we are doing and we'll talk about today overlapped with some of the recommendations from ONC, and that is particularly around prior authorization and value-based payments. Our letter, which is linked on this slide as well for those interested in the detail, highlighted the importance of healthcare operating rules supporting standards to ensure common industry expectations across the industry, and that as healthcare transitions from fee-for-service to value-based payments, that there is a need for clinical and administrative operations to work in sync, and operating rules in particular can help with this convergence. And there's some examples in the letter itself as well. So with that, obviously there is a lot going on, and we welcome your questions and feedback on the work that we are doing. I'm now going to turn the presentation over to Christine Bernaska, who is our Director of Research and Measurement at CAQH, to talk a little bit about the results of the latest CAQH index. Christine?
Great. Thanks, Erin. Thanks, everyone, for joining. I'm just going to take the next few minutes to talk a little bit about the CAQH index, focusing on some high-level findings. So if we're looking at slide 15, I'm just going to give a little overview of what the index is for those of you who may not be familiar with it. So the index is a national benchmarking tool that tracks the adoption of electronic transactions as well as cost and time-saving opportunities. As Jessica and Erin had just mentioned, we just completed our 6th annual report. It was released mid-January. And we were able to create this with the support of many industry leaders as well as our advisory board. So with all that being said, we have now completed the 2018 report, and are looking forward towards the 2019 report. So what did we find? On a high level, we found that across all the transactions, adoption has risen. Unfortunately, we still see a lag in the dental industry, although progress was made this year. Interestingly, we have seen that volume continues to increase substantially, while on the medical side, manual transactions have declined. And so we'll dig a little bit deeper into that so you can see where those breaks occur. Some of the most exciting news that we had this year was that the savings opportunity declined for the first time in CAQH industry history. And so again, we'll talk about that a little bit more. The next few slides are going to present some of the high-level findings associated with those general findings that I just mentioned to you all. So looking at, and I'm sorry, Jessica, I don't know what slide I'm on, but looking at the one that talks about electronic adoption improved for most transactions in the medical history. When you're looking at this chart, you'll see that adoption improved for all transactions with the exception of remittance advice. If you take a look at remittance advice on the far right, you'll see that there was an actual drop in adoption by 8 percentage points. Interestingly, that drop was taken up in portals because we saw portal use increase by 7%. And it's interesting to note that this is the only transactions where we actually saw portal use increase on the medical side. While RA did drop, as you'll see, I circled 3 numbers here. I think we need to note that 3 transactions now have reached 80% or above. And we'd like to note that. And you'll also see the difference when we look at the dental industry in terms of where their adoption is and where the highest levels are for that industry. While Erin had mentioned PA and there's a lot of work going on around prior auth, you'll see that that adoption still remains pretty low. I mean, when you look across all these transactions, prior auth, although it did increase by 4% this year, is still significantly lower in terms of adoption among all of the transactions. So when we dug a little bit deeper into that, we found that there could be various reasons as to why. So one of the reasons that we found was that in general, there's a lack of vendor support for prior auth. For the 2017 index, we actually did a sub-study and looked at vendor services related to the transactions. And we found that only 12% of vendors actually offer services related to prior auth. In addition to that reason, if you look at some of the state rules and regulations around prior auth, you'll see that some states actually mandate manual processes occur while completing a prior authorization. And then finally, there seems to be, as you all may be well aware of, there's a lack of consistency among plan regulations and requirements. So it's difficult to standardly submit anything or work around that prior authorization and any sort of consistency. So I thought, so those are some of our reasons, and I just wanted to share them with you as you think about prior auth and you think about the index findings. Moving on to the next slide, we'll take a look at dental adoption. And what you'll see on this slide is that adoption improved for all of the transactions except for eligibility and benefits and claim status. And in both cases, adoption dropped 8%. Looking into those transactions a little bit more, it's interesting to note that in both cases, manual use increased for those transactions. So for eligibility and benefit, manual use increased 8% and claim status inquiry increased 18%, which clearly impacted the electronic adoption rates. While manual use was also up, volume also rose for these 2 transactions significantly. We saw an increase in eligibility and transaction volume up 40% from last year, and the volume for claim status increased over 100%. And so these 2 factors, the volume, the increase in volume and increase in manual use, it could have had a large impact on the adoption rate. Moving on to the next slide, when we look at volume overall, you'll see that volume increased for all transactions with the exception of medical manual. So I mentioned that in our high-level findings, and you'll see that it dropped anywhere between 1% for providers and 6% for health plans. Conversely, you'll see that the medical electronic volume increased by about 18%. So you'll see the 19% for providers and 17% for health plans. Flipping over to the dental side of things, you'll see that volume increased for all transactions by 15% or more. Moving on to the next slide, one of the most exciting or interesting results we found this year was that the saving opportunities decreased overall for the industry. So you'll see we went from 13.1 billion to 12.4 billion, which is a decrease of 5%. And this is the first time that we've seen a decrease in those savings opportunities. If you look on the right-hand side, you'll see where the savings occurred mostly, and the drop was driven by the medical industry, where you'll see a $1.3 billion drop. Conversely, you'll see that there was a small increase in dental savings opportunities. So looking over time, I had said that the drop in savings opportunity was the first that we have seen since the start of CAQH reporting the index. If you look at the trend, you'll see in general, as volume increased, so did savings opportunities. But for this year, while volume increased by 18%, you'll see that the savings opportunity dropped by 12%. And so this could indicate to the industry that perhaps we're becoming more efficient, that people are using more electronic transactions, which could result in more savings and more savings in terms of costs and savings in terms of time. So while those are some high-level findings, you will see in the report online that there's additional details around specific savings opportunities related to transactions, as well as specific time savings opportunities. So please feel free to go to the CAQH website and review the report there. We also have a recording of the webinar that we did related to the results and the slides. And as always, please feel free to reach out to anyone here. You can reach me at the explorations@caqh.org email if you have any specific questions. So in closing, I would like to ask you on the phone to either participate in the index as a data contributor or as what I'm calling an index supporter, which is someone who could promote participation and involvement. As I'm sure many of you are aware, the data is only as good as the data that we receive, so we are always looking to increase the sample size from a provider, plan, and vendor perspective. If you do participate, all participants receive a benchmark report, which allows, specific to their organization, which allows an organization to compare how they are doing relative to the industry overall. And we've been told by many that the report is useful for planning and strategic decision-making, and that in some cases they've brought reports to the board meetings and or executive level meetings just to help figure out where resources should be allocated and what they can expect or should be expecting if they change over more to an electronic adoption system. So that is all I have for the index. There's, as I said earlier, there's a lot more that can be discussed, and please feel free to take a look at the index report and let any of us know if you have any questions. Thanks, Jessica and Aaron.
Thank you, Christine. And, you know, this is a great segue to our first polling question, which I think we can go ahead and launch. We want to know whether your organization's interested in participating in the next index. This information will be helpful to us in our planning, and also we can start outreaching to folks. So if you're interested, feel free to say yes, and or unsure, we're happy to give you more information if you're not sure whether this is something that makes sense for your organization. And we are always happy to hear that organizations are already participating. So I think we will, let this poll run for a few seconds. and we'll just, we will use this information for our planning purposes, but this is very helpful and we appreciate your feedback. So let's go ahead and close the poll. And with that, I would like to introduce our next speaker, who's going to update us on CAQH Core's work on value-based payments. Lena Geber-Mariam, who's a core manager. Go ahead, Lena.
Thanks, Jessica. So moving on to the next slide. As many of you may know, in 2018, CAQH Core released a report on streamlining the adoption of value-based payments. This report identified 5 areas that, if improved, would improve the implementation of VBP and relieve administrative burden. These areas, as you see on slide 26, are data quality and uniformity, interoperability, patient risk stratification, provider attribution, and quality measurement. Core's vision for VBP is a common infrastructure that drives the adoption of VBP models by reducing administrative burden, improving information exchange, and enhancing transparency. VBP models run the spectrum from fee-for-service with quality incentives to full capitation. So any solution that attempts to ease administrative burden in VBP will need to work regardless of model. In looking at opportunities that would improve administrative burden across models, it's important to look at where the commonalities in these models lie. So what we did was, since the release of the report, is research into the revenue cycle for fee-for-service, as we see on this slide, and where the differences lie for the revenue cycle in VBP models, and amongst the different VBP models. What we found is that most models still use the fee-for-service revenue cycle, but the data needs are different, and also when that data is needed, it differs. For example, in a standard fee-for-service structure, when a patient encounter is scheduled, a provider will run an eligibility request to a health plan to determine whether the patient is eligible for the service and what their health plan benefit structure is. Providers participating in VBP models still need to know this information, but they also need to know whether that patient is attributed to their population. Currently, providers often know a patient's attribution status months after the encounter has already occurred. An opportunity here would be to work within the provider workflow and return patient attribution information when a provider submits that initial eligibility request. So there are several other examples on this slide, but these are all just examples of opportunity areas that CAQH Core could pursue. In order to determine which opportunity area is appropriate for us to pursue in the near future, we have formed what we are calling our VBP Advisory Group. This advisory group, which meets for the first time tomorrow, is made up of 12 executive leaders from leading healthcare organizations who will identify and select specific strategies for a CAQH subgroup to pursue, which will result in a predefined work product or deliverable, such as the example seen on the previous slide. And you'll see on the next slide that we anticipate this group working through the first half of the year to prioritize and narrow down the list of opportunities, which will then be handed off to the subgroup. And this subgroup would be open to all core participants. While the subgroup is running, the VBP Advisory Group will still be available to provide continual feedback and support. So if you're interested in learning more about our VBP initiative, feel free to type in the chat box or email us at core@caqh.org. And now I'm going to pass it off for an update on attachments with Bob Bowman, our CAQH Core Director. Bob?
Great, thanks, Lena. And just as Lena mentioned, we do want to provide a quick update on the work that we're doing for attachments. What that means is that we have actually completed our environmental scan and are working through the findings. We'll soon publish a white paper for the industry to consume and share some of our more important findings. These findings really fall into 6 main categories. The 3 you see here on this slide, the attachment profiles, which, as you can imagine, we're trying to identify exactly the different types of attachments that are conducted and transmitted from health plans and providers today. 70% of those attachments, as you can imagine, are still coming in the form are being conducted or exchanged through mail and fax, only 18% through web portals and 12% through EDI. We did find some interesting trends through the dental and workers' compensation markets where they actually have advanced through various types of attachment formats and portals. So again, some interesting findings for that particular market segment that we'll share with the industry. Other findings related to time resources relate that it is still very costly, both in the cost for full-time employees as well as resource hours, counting in the hundreds of hours per week to process the attachments. It also has a direct impact on the revenue cycle as well, because claims that are received through the mail with an attachment take 44 days to adjudicate, whereas claims with attachments received through EDI take 2 days to adjudicate on average. So some important findings related to the times and resources for the industry. Next is the category of adoption. Many of the respondents still have identified waiting for a regulatory requirements for attachments before moving forward in the industry with adoption. So definitely a burden for the industry, as there's not been a consensus on exactly where that should be. Only 9% of the respondents reported that it was budgetary constraints that were holding them back from moving forward with different types of technologies and standards for attachments. Also really important for the industry is that there's been a number of pilot programs that have been launched over the last couple of years. We've had some direct insights with many of those participating programs, interviewed many of those participants. We'll be able to share some of those findings as well. The other 3 types of important industry elements that we've considered for the environmental scan was honestly the data content, the formats that come in for and are used by vendors and health plans and providers. As you can imagine, many of those types of formats include the PDF as well as image files today. There have also been a number of conversations related through our environmental scan related to the common data fields that are going to be important for attachments. Everything from an NPI to member ID, date of birth, first name, last name, some very common demographics that are going to need to be consistently used to identify how this particular additional documentation of attachments relates to a claim or to a prior authorization or to an audit. Another important factor for us is the infrastructure requirements. With only 25% of the health plans reporting that they actually acknowledge the receipt of an attachment, providers are often left in the lurch, so they don't know for sure if the attachment's been received or not. So that makes the providers anxious, it makes them resubmit, it makes them use a more costly means of submission like the certified mail. So nearly all stakeholders in our environmental scan reported infrastructure needs for connectivity, security, response time, companion guides should all be considered as we move forward as an industry. Last but not least, the 6th category is the business needs. A majority of stakeholders did report that a real-time attachment scenario would be preferred. Many health plans also would prefer a solicited approach. However, that does not perhaps take the needs of providers into account, as they really want to make sure that as they are submitting a claim or submitting a prior authorization, that the required documentation that would support those is also sent in. So the unsolicited approach is going to be important for providers. All of that leads to lots of debate within the industry of where we need to go. We hope that with the publication of our white paper hopefully at the conclusion of the first quarter in 2019, with many of the findings that we'll have, we hope to help provide some guidance for the industry on where we can go. As Aaron mentioned earlier, there's the potential for an NPRM related to attachments that will come out this year, and we are ready to launch an attachment advisory group and subgroup when that occurs, and ensure that we're part of the industry and leading that implementation process for any potential standards. With that, I'll hand the call over to Jessica for our second bullet question.
Thank you, Bob. We would like to hear from the audience once again. We want to find out, where are there some knowledge gaps? Where would you like to learn a little bit more? This could be in a webinar that we put together or a white paper, but feel free to let us know which of these topics you'd like to hear more about. And it's a check all that applies, so feel free to check more than one if you want to. I think this is one that would be interesting to share, so let's just give this a few more seconds and share with the audience. And I may ask Bob whether this is consistent with what he's seen in his work on attachments. Let's go ahead and share the results. So looks like an even split. Bob, what do you think? Do you think is this what you expected?
Yeah, definitely. I think that both plans and providers have concerns with the workflow and the impacts that it may have by adopting a standard or a standard process. And operating rules can adjust those workflows. So definitely lots of concern and lots of input is going to be needed as we define those workflows and the best workflows. And many of that is related to the solicited and unsolicited workflows too. How do those attachments come in from the provider? How does the health plan process them? How do they acknowledge them? Ensuring that the provider is kind of kept in the loop all along the way. So that is really going to be important between the workflows and unsolicited. So I'm not surprised by the results that have come in.
Great, thank you so much. And so Bob, I'm going to send it back to you to give the audience an update on our work on prior authorization.
Great, thank you. And again, we do want to provide an update on the work that we're doing for prior authorization. As many of you know, the vision that we have for prior authorization is to take a step-by-step approach with the industry, move the industry along to a more automated approach, because many of the steps and the workflows and the processes today are really way down there in the red, right? They're very manual. Very few parts of this are actually automated or even semi-automated. What we need in industry is a kind of level set the entire network or system. We've tried to do that with our phase 4 operating rules, and we've seen many entities are going through that certification process now that really is allowing them to build the infrastructure requirements, the connectivity, the security, the acknowledgments that have been really important for providers. To build that type of system and network, let it mature. And now we're working through phase 5 and looking at the data content requirements for the 278 transaction, as well as the web portal requirements, because many of these transactions are still conducted on a web portal. And how can we as an industry move each one of those methods of PA submission to a more automated, more singular approach when it comes to ensuring a timely adjudication of the prior authorization, a final determination, and trying to impact patient care in a positive way. So what we've been doing over the course of the last couple of months is actually looking at and seeing how we can actually build those data content requirements. And we've completed that development process. As you can see here, we looked at very specific things related to the 278 transaction, related to consistent patient identification, ensuring that the provider submits the correct data or the data that's going to be necessary or needed by the health plan to appropriately adjudicate that request for PA. Also looking at diagnosis codes, procedure codes, and revenue codes. The code values that come in on that request can have very specific decision tree logic at the health plan. So how do we ensure that the health plans are building the right decision trees for the right types of codes to identify which ones require PA, which of those require an attachment, which of those will be pended, which will be denied. All of that information will be really helpful for providers as they set up the PA request. Consistent use of the codes will be very important, not just when it comes with the inbound transaction, but also the outbound response. As the health plan adjudicates a PA, the coding that they send back to providers is going to be very important. It'll tell them why a PA pended, what type of attachment is required to remove the pend from the PA. That coding, making it consistent for every health plan using the same types of code for the same reasons, that makes it much easier for providers to implement the transaction. Last but not least, detection and display those code descriptions. A code of 428 means nothing to a provider. They would have to go look that up. So if a vendor has a solution and actually can describe and display what that code value means, it allows the provider not to break from their workflow. They can continue moving forward. Also, the next rule that we have is specific to the web portal. There's very important requirements that we've defined for web portals. Many of those related to system availability, reporting when the system will be down and unavailable for processing prior authorization, application of the X12 data field labels to web portals, again, making it uniform and consistent, the language that providers see across portals, because many providers have to interact with many portals, right? About 18 different plans that every provider has to touch. That's 18 different portals. And if every plan named it differently, it makes that burden on the provider. And last but not least, confirmation of receipt. This is also came up again here, not just an acknowledgement for attachments, but acknowledgement for receipt of the PA. Some way informing the provider that the health plan has received the prior authorization, it's going to enter into the workflow of the health plan, and it's going to move forward. And just as a way of an update for the work that we've completed recently, what we've done is that over the course of the last quarter, Q4 of 2018, The rules work group has gone through iterations of the rule, defining the requirements, adjusting the requirements, straw polling, voting, and balloting all on the requirements. So that has made some adjustments to both the web portal as well as the data content rule. You can see those there. Don't want to get into too much of the detail, but those are provided there for you. What's important for you to take away is that through the month of December, the rules work group did complete their ballot. It does require a 60% quorum. We've had a 69% quorum on the ballot vote. Also required is a 50% or greater response rate in a positive, the yays. And we had actually 80% for data content and 75% for web portal. So the rules are draft, however, they are complete. They are being moved into the next round of our processing, which is to actually define a core certification test suite for the rule set. So the certification testing subgroup has completed their work. They have polled the test suites, and this is basically gives all the definition for how an entity would complete voluntary core certification testing for phase 5 for these particular requirements. So the technical work group will launch February 5th, next week, and we'll be reviewing the test suite, and we'll be balloting the test suite as well, getting ready for the final core vote, which we have on the next slide. Just some high-level milestone dates for you. You can see the work that we're going to complete here through the first quarter and into the second quarter, with the all-core vote taking place in March, moving to the board vote in April, and then publishing the certification testing site by the end of the year. So entities will be able to certify their systems, their applications, their software by the end of the year for phase 5. So very exciting times, lots going on. Again, we have defined very specific requirements for phase 4 and phase 5 for the prior authorization, both the 278 transaction as well as the web portals. We're also looking forward to working with other entities within the industry on potentially expanding some of the scope of phase 4, looking and seeing about what is there potential available there for additional requirements related to final determination timeframes, looking at running pilots with the technology that is defined in phase 4 as well as new technology that's emerging. So if you're interested in any of that, also let us know. With that, we're going to move into a quick update on our certification process. And again, our certification has been around for as long as CORE has been around. We've completed our certification testing program for phase 4. Many of the entities are now going through phase 3 and phase 4. We still have some laggards catching up with phase 1 and 2. What's important to understand is that the certification process is defined by the industry for the industry. Again, CAQH just acts as a reviewer of the information. All of the industry works on, all of the core participants work on identifying the specific requirements for certification, how each requirement is tested. And again, we act as that neutral certification administrator. Important for us to know, we do want to thank some of our latest and newest core certified entities, Regia and Waystar. This month, we have completed 350 certification seals to date. It's a great milestone for us. We've had a number of new core endorsers as well that have come on board to endorse the work that we're doing and endorse the work that the industry is doing and ensuring that entities are pursuing certification. Again, a really important factor for us. And with that, I'll hand the call over to Jessica for our Q&A.
Thank you so much, Bob, for giving us those updates. So now we do have time for Q&A. I'd like to remind you to please submit your questions by typing them into the questions panel on your dashboard. So let's see, we do have a couple of questions coming in. So Christine, I think thanks for your lovely presentation and the polling question, we did get a question about participation in the next index. When does that participation begin? When do you start collecting information for the next index?
Yeah, great question. For anyone who's interested right now, definitely feel free to reach out to me and I can talk with you more about what it requires to be a participant. participant and what you'd be asked to complete. We are right now aiming to begin recruitment in May and end data collection in August, with the thought that we would then analyze the data, report out on findings sometime in January of 2020.
Thank you so much, Christine. We've got one question related to PA. When do you anticipate the PA rules to be ready for implementation?
Great question. The all-core vote and the ballot will start in March, and the core board will complete their work in April. So that's when it will be truly final, and the certification test site will be available by the end of the year. So it now is actually a great time for entities to start the remediation process, which can take quite a bit of time for some plans and some vendors. You want to go through your system remediation plans, you want to get a budget, look at where your system is at today, where it needs to be to meet the requirements for tomorrow, schedule that work, get those resources scheduled, get the particular release identified. If that is all part of your process. We also want to ensure that if you're going to pursue voluntary course certification, if you are an early bird, we'd love to have you as a potential beta tester towards the end of the year. We're always trying to recruit testers to ensure that the test site is up to date and working for every stakeholder type. So we'd love to recruit a health plan, a provider, a vendor, someone that is in each one of those stakeholder categories that can actually test the site for us and become a beta tester. So those are all important. That's all work that can be done this year.
Thank you, Bob. That's really helpful. And if, again, you can always contact us if you need a little bit more guidance on that. Bob, so this is another question for you, and I think this might be more clarifying. Does workflows equals portal, or is that a separate topic?
So it's a great question, because what we've seen both for attachments as well as PA, there's such a heavy reliance on portals that it does directly impact the workflow for providers. Many health plans have promoted their portals for use. It is much easier to use a portal than it is to drop something to mail or to fax something in or to pick up the telephone for an IVR system. So portals are a great tool, but there are limits with those, and it does impact the workflow that providers have. So they often have to get out of their PMS system, their EHR system, and then log into a proprietary web portal for every health plan. So it is definitely a challenge both for providers to use these tools, but the tools are very helpful as well. Right? So there's a yin and yang. What we're doing here is making sure that we can identify where operating rules can come into place at each step of the process. So it might be collecting the data from the EHR, populating it into a PMS, populating it into a web portal. How's the best way to do that? Is there any sort of integration? Can we work with vendors? Can we work with EHR vendors, PMS vendors? PMS vendors. Is there some sort of integration? Can operating rules help there? So long-winded to say that operating rules can help. The industry can come together and work on very specific things, and the workflow is really important. So we're looking at the workflow, we're looking at how operating rules can impact that at each step of the process.
That's really helpful, Bob. Thank you. So Christine, we've got another question about the index, and this one's related to timing. So this latest index came out in January, the one prior came out in May. So what can you tell us about the timing for the next index?
Sure. We anticipate releasing the 2019 index in the beginning of January, or sometime in January 2020. The 2017 report was a little off cycle due to some staffing changes, et cetera, but we are now aiming for January of 2020, and I think that is very doable.
Thank you, Christine. That's helpful. So a question came in, I think people are sort of looking for information about, who is going fully electronic versus partially. Do we know of a resource for people to find that kind of information?
It's a great question. I think we can probably follow up directly with the individual submitted the question with some of the folks that we've worked with directly, but I think generally speaking, there are many vendors in the space that offer solutions that can assist in many parts of the process. There are a handful of vendors and providers that are fully automate the entire process, but it's usually for very specific use cases. As I mentioned with dental and with workers' comp, just for attachments, there's some of that type of development's been done for imaging for prior authorizations. So there are specific vendors out there that do imaging and imaging only, and many health plans have contracted with this vendor. Many providers know to use this vendor if it's just imaging. We're seeing the same thing with EPA for pharmacy. There's specific vendors for EPA, and those vendors have a very large stake in the ground, so kind of the first ones to the market. So there are some of those types of vendors out there for very specific use cases, and many of those vendors are trying to expand and grow into other use cases as well.
Great. So Bob, we do have, I think people are interested in, the phase 5 rules. What could people be doing now to plan and prepare?
Yep, great question. I think that, as I mentioned earlier, that now's the time to really kind of review and consume the phase 5 operating rules, see where your system or process or workflow is at today, and what's the impact of that. So we're actually putting together tools now, and they should be available shortly to the industry, and they'll be free and available on our website as they are for every previous phase, but it will actually be basically a spreadsheet, and you will be able to track all the requirements and what kind of system remediation is required. Is this a technical solution that you'll have to build? Is this a workflow process? Is this education for your staff? It will help you identify each point that the rule requirement touches within your own software, within your own system, with your own workflow. And once you have identified those, you can build your remediation plan. You can build the technology that you need to replace, build in those systems, those applications, as well as build in the new business processes and functions. So hopefully the tools that we've built for previous phases will be duplicated here for phase 5. That will give you a leg up as you build your remediation plan. And you'll be able to implement that remediation plan on your schedule. Again, if you'd like to volunteer for a beta tester, we'd love to have you as well.
Thank you, Bob. So we've got some questions about, what are the benefits of core participation? Erin, are there anything you can share for folks who are interested in becoming core participants?
Yeah, there's a lot of great benefits of becoming a core participant. I would say the number one benefit is having a direct impact on the operating rule development process. It is our core participating organizations that come to the table with ideas. They vet and discuss and debate all of the potential ways in which we could improve the efficiency of how information is exchanged within healthcare today. In addition to that, the core participants provide us valuable input on things like the NCVHS Predictability Roadmap. So we have special sessions with just the participating organizations where we get feedback or provide information to them as a group, as well as the opportunity to co-chair and lead our workers in subgroups. Finally, having a role in our education and outreach arm is another opportunity through core participation. So many different benefits to get involved.
That's great. And there's more information on our website, too. There's a core participant, there's a join core part of the website. If you're interested, make sure to check that out. So we have time for one more question. So you mentioned workers' comp and attachments. Do you have any more findings that you can share regarding that?
Yeah, definitely. We hopefully will have more to share soon from our white paper, but the work that we've done with workers' comp and the entities that worked as part of our environmental scan, they shared that they've been really great with working with individual states, and individual states have passed regulations. So it's kind of a hodgepodge, mismatch all over the country, but many of the workers' compensation claims are now coming in on the 837, although they're not required to. Many of the attachments are coming in on a 275, so they're using HIPAA standards, although they're not required to. So it's a great way of it's a great example, I think, of the industry coming together, identifying very specific business needs, identifying standards and using them kind of holistically. They found that the best approach that's worked for them. Many of the vendors in this space have been working very closely with the states to do this and implementing them one-off, very close pilots. So there's also lots of findings there too. We can identify very specific use cases, very specific success stories by looking at something like workers' comp, as well as the dental industry has a very similar approach, where they have had very kind of like national vendors have stepped up to the plate, have built systems and utilities that are used throughout the country for dental claims and dental attachments. So it's a totally different approach than workers' comp, but also both have been very successful for the industry.
That's very helpful. Thank you, Bob. So I think we've run out of time for the Q&A. So on this slide, Erin did a lovely job of going through this slide. Thank you very much, Erin. I appreciate that. The only thing I will add is in the various presentations, we talked about advisory groups and subgroups. If you go to our website, the Join Core part of the website, it does talk about which work groups are active and doing what. So that's a really helpful resource for all of you. On the next slide, I want to point out the conferences and webinars that we have coming up. One thing for those of you that are core participants or who might be interested in becoming core participants, we have a call scheduled on February 22nd when we're going to have our board members and our leadership here at CAQH Core share the goals for 2019 and some of the new work that we are undertaking. And then if we go to our last slide, this is the information, our website, our email. Please feel free to give us a call if you have any questions, and we thank you very much for joining us. Have a great afternoon.